Okay. Good morning, everyone. My name is Michelle Jackson. I'm one of the co-chairs of the Pediatric Cancer SIG. I think we're going to go ahead and get started today. We have a wonderful presentation by Sarah Stallin on a previous publication that her and several of our other SIG members were a part of. I wanted to give you a little bit of information about Sarah if you're not familiar with her personally or professionally. She is a certified genetic counselor at the Department of Pediatrics at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. And Sarah has been in that position for a little bit more than 2 years, I believe, or maybe a little bit more than 3 years. Sorry, Sarah. And then prior to that was also a genetic counselor and project research specialist for the Hawaii Department of Health for about 5 years before coming to Texas. Sarah has been involved in many different aspects of pediatric cancer and has several publications in this topic area, and I would say is a leader in this field for sure. So we're really happy to have her talk about her publication today. So Sarah, I will turn it over to you.
Are you able to see my screen?
Yes, I believe so.
Okay, and are you just seeing my slides or are you seeing the pop-up?
I'm seeing your slides.
Okay, perfect. So thank you for the introduction. And I've actually been faculty here for about 3 years, but I've been in the position for a little over almost 6 years now. So,
Okay.
What I'm going to do today is just share with you a little bit about a recent publication or review article that myself and some amazing co-authors, because this was quite a project, put together called A Comprehensive Review of Pediatric Tumors and Associated Cancer Predisposition Syndromes. And because it's a review article, it's not that there's new research necessarily to present, but some of the things I've been asked to present on were really kind of the process, the things we ran into along the way. I will share some highlights, but also it is a big article, and so I was just going to share a little bit with how to navigate through it and just some of the purposes of how we put it together. So just some background for the review article. This started a couple years ago that the Cancer SIG actually put a call out for volunteers to develop a review specific to pediatric cancer susceptibility syndromes. At the time, there were several existing, and they were wonderful reviews that were out there, but they were really focused maybe on the most common pediatric tumors or common syndromes, or perhaps reviews on subclasses of tumors, nothing that really had put everything together. And at the time, there were several new things being described. It was time when Dicer 1 was becoming, kind of hitting the publications, as well as constitutional mismatch repair. So really looking to put together a comprehensive review that put all the updated information into one place. And also this review really could lay the groundwork for looking at things like recommendation papers in the future. So in the interim, as from the time that we were asked to do this, as we began to write this, the field really began to grow. When we started, or at least even when I started in this position, there were just a handful of us, at least that knew about each other, that were doing running these clinics. And since that time, this subcommittee was formed. Based on the most recent referral guide I could find, there's now 32 clinical sites offering this specialty. And then also during the interim, new genes and gene associations were being discovered. Some of the initial challenges as we sat down to think about how to do this was, first of all, just how to organize the review article, deciding what tumors and syndromes that we wanted to include or exclude. Also, we knew that this was going to be a lot of information, and we did have some conversations about potentially breaking this down into a series of reviews, and I'll kind of get to our final conclusion in a second. But also, and then thinking about, should we include only the strongest associations, and if we did that, what would be the cutoff for those associations? The term of automatic referrals, which I know the subcommittee has talked a lot about, came up. But our final decision was really just to put together a comprehensive review that would serve as a starting place for a genetic counselor or other health practitioner to go to if they received one of these referrals. And we did decide, instead of breaking it down into a series, to really just try to put everything into one place, recognizing that we would probably have to go broad and not very deep, and to think about how we needed to do that. The design that we came up with is ultimately we decided to organize by tumor type, and the thought process being that most often that's what we're faced with in clinic. So we have a referral come to us that a child has this type of cancer, and what would you then think about as opposed to organizing it by syndrome? And we divided it up. So when you go through the review, it's actually organized by body system. So there's the central nervous system tumors, peripheral nervous system tumors, non-CNS solid tumors, and then the hematologic cancers. And within those, we then break down by tumor type, and some of the tumor types are then broken down into subclassifications. So that's really the organization of the paper. But one thing that I do want to point out, and I'm going to touch upon as we move through some case examples I'm going to use, is this review is not meant to be a referral guide. So the associations that are reported within the review range anywhere from these high risk, what we might consider an automatic referral, to rarely reported case studies. And the idea for us, that was a decision that we had to make along the way. You know, there were points when we questioned whether we should put these more rare associations in, but felt that it was important because then it would be there if anything similar presented in your clinic. We sat down as a group and we came up with the list of possible tumor types that we thought could be referred to a pediatric cancer genetic clinic, and we did decide to include both cancers and benign tumors within the review. The tumors were divided amongst the authors by if we had expertise, you know, individually or in our institution, and also just by interest. And then each of us did in-depth literature reviews. And once those were completed, all sections were reviewed and revised by each of the authors. And along the way, we came up with the ideas of the tables that I'm going to show you that really were meant to supplement the manuscript content, because we realized we couldn't put everything within the manuscript. And I do want to point out this review underwent several revisions. It took quite a while to put it together just because of all the changes that were happening in the field. And also, I just wanted to point out the benefit of peer review, that we got wonderful reviews back as far as input from our peer reviewers, and that really helped shape this up into a good paper. And so I just think that's a good point to make. So I explained kind of the organization of the paper itself, but I just kind of wanted to walk you through the actual tables and how to navigate these. I will say that we were kind of bound by the publishers as far as how these were organized, so they're a little difficult to read without lines. But so the first table is really just meant to be a quick reference guide for the pediatric syndromes. And the reason we developed this table is because we were not able within the text to really go into depth about the syndromes that we were describing. So we just make mention of the syndromes that are associated with the tumor, with the idea being that then individuals could go to this table and learn more about the characteristics of the syndrome. So the first column is going to be the syndrome itself. The next column is going to tell you the genes that are associated. Then you have your inheritance pattern of the syndrome. And then we included the primary associated tumors or cancers. We did include both pediatric and adult here to be comprehensive, but I kind of emphasized the primary. So these are certainly, I'm sure there are some associations that we may not have included here, but these are some of the more common ones, should be in this category. And the same goes for the other clinical features. So we included clinical features associated with the syndromes that were some of the more common associated features. So table 2, this kind of can serve two purposes. So this is actually going by tumor type and then looking at which syndromes are associated. One thing that I want to point out is that, these syndromes as they're listed, it's not by hierarchy, so it's not the ones at the top are more likely to be associated. They're just as they are mentioned in the paper. And some of the syndromes to keep in mind, like I mentioned, may have just been in a case report or kind of a rare association. So keeping that in mind when you're looking through the syndrome list. But also this, this table serves somewhat as a table of contents because the tumor types are listed in the table as they appear in the paper. So if you're kind of looking for one particular tumor, this might be a good place to start if you can't find it in the paper. So next, I just wanted to go through a couple cases, and the cases demonstrate different levels of the strength of associations, as well as we get into case 3, how you might utilize this paper. And I don't expect you guys to answer, so you can just kind of think about these answers as you go, because obviously we're on mute. So case 1 is you have a 9-year-old male who's referred to your clinic based on the diagnosis of a SEGA. Prior to the identification of the tumor, he had been a healthy child. There's no additional family history of cancer within the family. So what syndromes might you consider in your differential? And this case is a good example of a tumor that's pathognomonic for a condition. So SEGAs are associated with changes in TSC1 and TSC2 associated with tuberous sclerosis, and really tuberous sclerosis is the only predisposition syndrome currently associated with SEGA. So this is kind of one of your slam dunk tumors is where we would start. And thinking about SEGAs and tuberous sclerosis, SEGAs arise in about 10 to 20% of individuals with TSC. The mean age of tumor development is about 9.4 years old. And as I said, they are almost always associated with TSC. There are case reports of these tumors isolated SEGAs, although it's possible these may have somatic mutations in these genes, or they might represent somatic mosaicism. So case 2, this is a 3-year-old child who's referred to you with adrenocortical carcinoma. The oncologist contacts you for your opinion on whether the child should be referred to cancer genetics clinic. He reports that there's no significant family history of cancer, and the child does have an older brother with epilepsy. So now you have a case that's come to you where you have a child with a tumor, no real family history, just this piece about a brother with epilepsy. So what would you do? And the answer to this is you would refer. And the reason being is that adrenocortical carcinoma in and of itself meets NCCN guidelines for germline P53 testing, regardless of family history. And so in this case, you do genetic testing for the TP53 gene and you find a pathogenic variant. So thinking about ACC and Fraumeni syndrome, ACC is considered a core tumor in Fraumeni syndrome. Approximately 50 to 80% of all children diagnosed with ACC have LFS. And of the patients who have LFS, 7 to 10% will be diagnosed with an ACC. The incidence does seem to decrease with age in individuals with Fraumeni. And I use this case, though, to point out that although that's kind of the first thing that you would probably think of and should probably think of, that there are more rare associations. And so this would be an example of one where there's other conditions mentioned that may be lower on the totem pole. So fewer than 1% of individuals with ACC have Beckwith-Wiedemann syndrome, but of those with Beckwith-Wiedemann, about 15 to 20% may develop an ACC. It also can be seen in isolated hemihypertrophy or hemihyperplasia, and then there are reports of ACCs being associated with a handful of syndromes, which I have listed there. And this, again, would be an example of a case that, although Fraumeni would probably be the first thing that you went after, if you did see other features in this child, there are other conditions that you may potentially think of. So case 3 will get a little more complex here now. So a pediatrician contacts you regarding a child he sees in pediatric practice who was recently diagnosed with a medulloblastoma at the age of 18 months. The child has macrocephaly, however, the family reports that the father also has a large head size. The physician is concerned because the child's mother was recently diagnosed with breast cancer at the age of 32. The father also has a history of skin cancer with really no further detail than that, and you discuss with the physician that this would be an appropriate referral given the complexity of the case. So now, what cancer susceptibility syndromes do you consider in your workup here? And this may be one where you may turn to the paper. So you might go and look at the table 2, look up medulloblastoma, and consider some of the syndromes that are listed here. So your first one is nevoid basal cell carcinoma syndrome, or Gorlin syndrome. So right now already we know, the child has macrocephaly. There's this mention of dad having skin cancer, and you remember that Gorlin syndrome can be associated with basal cell carcinomas. There are medulloblastomas that are related to changes in the SUFU gene. These either tend to sometimes have features of Gorlin syndrome, but also might be isolated family histories of medulloblastoma. SAP is there, no real red flags of any colon cancers or colon polyps that are mentioned, but it's in consideration. Fraumeni syndrome raises a red flag because mom has an early diagnosis of breast cancer. The next ones following are a handful of autosomal recessive conditions. You may think through those. They typically involve other physical features that aren't really being described. You have constitutional mismatch repair, which is certainly a consideration. There's no real history that you're seeing on either side of the family of colon cancer. But we know in this condition that especially families who carry PMS2 mutations may not present with a family history. So these are some of the things on your list, but given what you know so far, Fraumeni syndrome's up there. You know a lot about Fraumeni syndrome, so you don't have to do too much digging. You haven't seen Gorlin syndrome in a while, so you're going to go ahead and go to the other table now and look at Gorlin syndrome. So you see Gorlin syndrome is associated with these 3 genes, autosomal dominant. Some of the tumors that can be associated are basal cell carcinoma, medulloblastoma, which is relevant here. You can also see fibromas or these jaw cysts, which we don't have any history of at this time. Some of the clinical features that when you're evaluating this patient and family that you might think about are that they have pits in the palms and the hands of the soles of their feet. They can have macrocephaly, a prominent forehead, and skeletal anomalies. So now the family presents to your clinic, and the pathology, you get the pathology report, and the medulloblastoma is a medulloblastoma with extensive nodularity. Mom actually shares that in the interim, she recently had BRCA testing and was actually identified to have a BRCA2 pathogenic variant. And this is important to think about. I mean, we recognize that at this time there aren't childhood cancers that are associated with BRCA1 or BRCA2 that we think of, but individuals, children can have recessive inheritance of the BRCA2 gene and have Fanconi anemia, which was on the list, but the child does not have any clinical features of Fanconi anemia. If you were really concerned, you could order chromosome breakage to somewhat quickly answer that question. But upon receiving further information from the family, you do learn that dad's skin cancers were basal cell carcinomas. On physical exam, the child is found to have macrocephaly and a large forehead. You do a physical exam on dad because he's there as well. He does, in fact, have macrocephaly, and you notice palmar pits. So at this point, you're leaning more towards Gorlin syndrome. You order comprehensive patch 1 testing, and that test comes back with a pathogenic variant. So this is a good example of where you really might need to work through multiple syndromes that can be associated with one tumor type. Another point that I want to bring up regarding the testing, and I'll talk about it a little bit more at the end, is that you'll recall that there were 3 associated genes with this condition, and really there's no consensus at this time of how to best approach that testing, the testing for the child. So do you go after one gene that's the most common? Do you consider doing a panel of genes? So that's something that certainly we don't have guidelines for or consensus on. In this case, I just chose to go with the most obvious gene first. So medulloblastoma in NBCCS, the average age of onset is between 1 and 2 years, which is compared to 7 to 8 years in the general population. And you can remember that this child had his diagnosis at 18 months. Studies report up to 5% incidence of medulloblastoma in individuals with this condition. The subtype does tend to be medulloblastoma with extensive nodularity. Mutations in patch 2 have also been seen more infrequently in NBCCS, And then as we've progressed, we've learned that individuals who are clinically diagnosed with this syndrome and have negative patch 1 testing, to my knowledge, patch 2 hasn't been available clinically yet, but someone can correct me if I'm wrong after my talk. But in individuals where the testing for patch 1 was negative, they were found to actually carry pathogenic variants in a gene called SUFU. And earlier in the talk, you'll remember I said that SUFU can be associated both with individuals who have clinical features of the syndrome, but also have been found in families with isolated medulloblastoma. And one of the reasons that this becomes important in the testing process is that initial studies have actually shown that those patients with SUFU pathogenic variants actually have a higher risk of developing medulloblastoma than those carrying patch 1 pathogenic variants. And so although I think we're still working out screening guidelines, I know at least here that we do consider doing screening for the medulloblastoma more seriously in our patients with SUFU than we would with our patch 1 patients. So this is an example where kind of working through the gene differential could be important in considerations for screening of these patients. So those are just a few examples to really kind of paint a picture of what I would consider the level of evidence of an association. And that was one of the challenges that we faced as we were writing this paper, is to really determine what, should we only include those slam dunks or those with a high association? Should we include these rare reports? And ultimately, as I said, we did decide to include the rare associations, and that comes with pros and cons, because I do emphasize, and we emphasize in the paper that it's not, you don't want to go ordering testing on those conditions, but they're just there for reference. But when you think through the levels of evidence for association, and I think the case examples highlighted this, you have your tumors that are pathognomonic for a condition, and LDD is another example of this. This is cerebellar dysplastic gangliocytoma. This, when you see it, you immediately think of P10 and can do testing for that. So you have your tumors that are kind of cut and dry on the association that you immediately think of. NCCN has helped us. This is the NCCN guidelines, and I think it's as recent as 2017 that these were added. But choroid plexus carcinoma, adrenocortical carcinoma, and embryonal anaplastic rhabdomyosarcoma, all within and of themselves without family history, meet testing criteria for P53 mutation. So if you see this tumor, regardless of the family history, P53 testing is recommended. And that's helpful. I think previously NCCN has mostly handled a lot of the adult tumors, so it's good to see some of the pediatric tumors starting to have guidelines for them. Medulloblastoma is a good example of a tumor where we really see multiple associations, and that at that point is when you really want to look at things like pathology, look at other clinical features, family history, those types of things to help point you in the right direction of what testing that you might want to do. I think those tumors with multiple associations is another place where we might start to consider panel testing as well. But like I said, that's not, there's no guidelines on that at this point. And then, of course, as I mentioned, there's the rare associations, and those certainly may end up not to be strong associations that we see again, but they're there for reference. Another thing that came up while we were writing was the variation in availability of technologies across institutions. So we recognize that everyone's not at a high-volume academic center who's trying to see these patients. And so including some of this information within the paper, recognizing that maybe not everyone would have access to doing this type of testing. So a few examples of this are, the first one is doing molecular, and so this isn't immunohistochemistry, this is molecular testing for somatic mutations in beta-catenin. And it has been shown that in desmoid tumors and hepatoblastoma, if you do molecular testing and it comes back negative, so you don't find mutation in beta-catenin in those tumors, then it is more likely to be a case where you might find an APC mutation associated with FAP. And so at least here, because we do have that accessible to us, we actually look at that pathology and oftentimes don't even end up doing the APC testing if we see that there is somatic mutation in beta-catenin. A second example is retinoblastoma. So not all institutions may be keeping tumor tissue to be sent off, but the tumor tissue, especially in unilateral cases, can be very helpful because the tumor tissue can be used to look at what the two hits in the tumor are. The lab can then go look and compare it to the blood sample and see if they find it in the blood. This is just, it's helpful in general for that, as well as picking up mosaicism because you know what mutation to look for and can find it at lower levels of mosaicism than perhaps you wouldn't have if you didn't have a targeted search. And then a third example is molecular profiling that's beginning to occur. So medulloblastoma is probably one of the first tumor types where we really saw distinct molecular profiles come out in association with outcome. And so medulloblastomas that fall into the sonic hedgehog P53 profile, these tend to be more aggressive tumors for the children, but also, and this isn't like a NCCN recommendation, but from the research, you can consider doing germline testing in these patients, but certainly not all of us have molecular profiling going on at our institution. Other challenges that came up, and I think this was probably the biggest challenge that we faced, and I think it's awesome that it was a challenge, but as we worked on this paper, new genes kept being discovered or new associations, and so these are just a few examples. With familial neuroblastoma, and I'm not sure if people call this by their letters or if they call it GALT14, but this gene became we became aware of it in 2015, where we had already known about ALK and FOX2B, but there was a newer gene, Wilms tumor, in 2014, CTR9 was reported, 2015, REST was reported. Leukemia that was probably one of our most evolving sections of this paper. We have learned so much about it in the last couple of years. So these are just two examples of genes that were reported, POT1 and familial glioma. And of course, these dates are some of the first case reports of these genes. So as you can imagine, there was some trickle effect as to when these became available as far as in clinical testing. So pediatric cancer is an evolving field, pediatric cancer genetics, and I think it is only going to continue to evolve. And so this is, as I said, exciting, but also proved to be a challenge because every time we kind of revised, we needed to go back and add some new information. Another thing that is interesting is the expanding phenotypes that we're seeing, and I just give two examples here, although I think that there are plenty. But the first is rhabdoid tumor predisposition syndrome. So when we first knew about this, there was only one type, and it was associated with SMARCB1 or INI1. We saw this in families with ATRTs or rhabdoid tumors. And then as we began to learn more, we found tumors that weren't missing INI1 and instead were missing SMARCA4, and we began to learn about this change. And so we knew now in these patients with ATRTs or rhabdoid tumors that SMARCA4 was kind of a second-tier gene we could think of. But then even further down the road, we learned that SMARCA4 is now associated with small cell carcinoma of the ovary, this unique ovarian tumor that we can see in young women, aggressive tumor. And this just kind of muddies the water because not only are we expanding rhabdoid tumor predisposition syndrome, but also how do we counsel these families as they come to us? So we just actually had a patient with the ovarian tumor who tested positive for SMARCA4 mutation. Probably by ascertainment bias, most of the publications currently out about that association look at families that have histories of ovarian tumors. And so what recommendations do we make for someone who presents to us with an ovarian tumor as far as ATRT or rhabdoid screening? And so these, we need to learn more about the way that these genes are working and these various associations. And a second example, and I used it in the previous case, is this patch 1, patch 2, and SUFU and the roles that this plays. And again, as I said, in this previous example, so these can be associated with individuals who have a Gorlin phenotype, but also SUFU can be associated with just seeing medulloblastomas or meningiomas in the family. So working to try to sort out these expanding phenotypes. And I think that these are only going to continue to present themselves as our technologies continue to grow. So the last slide is really future aims. And as I said at the beginning, the purpose of this review was really just to, it's kind of a jump off where you go to start to begin to think through your differential, and certainly especially for people who may be in clinics with less resources, it's an excellent resource. But I think that it is just a beginning point for where we need to go as far as publications and education in this field. Certainly this subcommittee has talked a lot about developing referral guidelines, and we've come up with our resource for that. But I do think that it's going to be important to try to standardize to some degree these referral guidelines and also educate our physicians and really come up with the list, whether it's going to begin at institutions, but the goal would ultimately have this be across institutions, that if a tumor type presents to your clinic, to know which ones to automatically refer and which ones maybe to ask a few more questions about. Also, as I alluded to in one of my case examples, is this consideration of what are appropriate testing strategies. When do we do single gene? When do we start to consider pediatric panels, whether it just is 3 genes that are associated as or up to going to a full pediatric panel. Certainly exomes are present. I've done a lot of work in exomes in our patient population, and so whether that's going to necessarily be the best resource as opposed to a panel is a question we're looking at, but certainly it's something we can see being applied to the field sometimes. Another huge piece is this role of molecular tumor testing that's going to come into our cancer genetics clinics. And this is, I think, is going to present in 2 different ways to start. The first is that these kids are going to be getting tumor testing done to think about treatment decisions. And as a result of that, we will detect germline mutations. And so thinking about how this is being done in our institutions, is appropriate pre-counseling being done with these families to know that they may find a germline finding? What are you going to do with these families when they present to you? We've all heard talks on having tumor testing coming to you and trying to figure out if that could be a germline mutation and when to test and when not to test. The second area I think it's really going to play in is the profiling. So I think that we're going to need to learn more about tumors probably than we did before to understand some of these different profiles that are coming out, and if that will make us think about germline testing, and I think that's only going to continue to grow. The next area is, once we find these changes, what to do next, and that's the screening guidelines. And so certainly there's actually going to be a series of publications through the AACR coming out in clinical cancer research, where a group of us, an international group, met to discuss what recommendations for screening should be used for these various syndromes. But there's still evidence that needs to be gathered, I think, even there. So this is a wonderful starting place, and I'm very excited to see them come out to reference. But even within those discussions, there were certainly areas for further research that we needed to look at. And I think the last piece, and this is just advocating for us, but continued education on the importance of genetic counselors in these clinics. Not only do we need to educate our providers about recognizing these families and continuing to recognize these families, but also the role that a genetic counselor can play within the clinic in helping to recognize the families, helping to test them, counsel them, and handle some of these things like I mentioned with tumor testing that may come up. So there are critical roles for us, and I'm so excited to see how many of these clinics have developed even in the last couple of years, because this is obviously one of my passions. So last, I just want to do acknowledgements, obviously, to my co-authors. This was this paper was a couple years in the making. It started, smaller, and it grew and grew, but we really wanted to stick to that goal of making this a comprehensive paper, and we're so excited to see it out and published, and I hope that people use it and find it helpful. I want to reemphasize our thanks to any peer reviewers. Some of you may have been them, I'm not sure, and just to encourage people who are working to publish that as much as getting these reviews back can be more work or sometimes discouraging, it shouldn't be, because this paper really was better because of some of the reviews and our answers to those reviews. And lastly, to the Cancer SIG for putting the call out to do this project initially, and then of course to the Pediatric Cancer Subcommittee for letting me present today. So with that, I am happy to take any questions.
Thank you, Sarah. That was an awesome presentation. I think that was very, very helpful. So I really appreciate you being willing and able to present that to us today. Right now, everyone is on mute, so I'm going to try to unmute everyone, and if you have questions, please feel free to, if it's really loud in the background, I might have to remute you. So if you're not able to speak, please feel free to use the question box and ask a question. But I'm slowly going through and unmuting everyone. So if you have questions for Sarah, please feel free.
I did want to note that one person had typed during the webinar that patch 2 is available through Invite. I just wanted to relay that.
I know, I was writing this now. I meant to go check to see if it was available yet. So that's good to know. Thank you for whoever gave us that information.
Sarah, I also just want to say thank you. That was such a great undertaking. I'm so glad you guys stuck with it and got this published, and it was very clear all the effort that went into it, and thank you for the webinar. It was such a great review. Even I, think I stay up on this stuff, and I learned a lot of stuff, so thank you. I was wondering, just in hearing your presentation, how different people are handling going back to patients. One of the populations that I serve is our survivorship clinic, and so I do have the opportunity, if they were a WILMS, to kind of update them on an annual basis regarding any new testing that might be relevant or things like that. But other things, I'm very much consultative and might see them one time as an inpatient or outpatient, and then really might not have the opportunity to schedule them for follow-up if they were negative. So are any of the centers for pediatrics, as we're learning more about new genes, like with medulloblastoma or WILMS, for example, do you have a process for going back?
We don't have a process. What we do, and obviously this then falls on the patient, but we do typically, if we didn't find anything in our workup, we may recommend that they come back in 2 to 3 years, especially in those cases where it's more open-ended. Some are a little bit more of a closed case. Our long-term survivorship clinic is good about checking back on those notes and check if the family doesn't check in with us. They often do. So that's one way that we've done it, but we don't have a systematic way of necessarily going back through our patients.
This is Cammie. I have everybody that does testing through me sign a piece of paper that on it says that this is a very rapidly changing field and it is your responsibility to contact me once a year so that I can give you updates. So that way it really is on the patient. But I also use the survivorship clinic frequently. But I feel like telling them to call me once a year is my way of saying it's on you.
And do they do that? And then how do you find the time to then, if they really are, go relook at their case? I mean, that's time consuming for not reimbursed time.
They don't follow up. But from a CYA standpoint, I feel like I went to a really interesting meeting at ACMG a few years back that really got me in this mindset that as long as we're clearly communicating that it's the patient's responsibility, I don't think it's really feasible for us to really keep up with everything with all recontacts of new options and new interpretations of variants. We don't always know that a variant's been reclassified unless we relook at the case again. And I don't think any of us could possibly keep up if we were the initiators all the time. So I feel like I just make it the patient's responsibility. I also try to encourage time points of kind of reproductive time. If their child's young, I say I want to meet with them more formally when they're about 12 to 14 to talk about recounseling and educating, as well as talking about reproductive risks, and then again at transition to adulthood.
Thank you.
Hey, this is Martha. Sarah, thanks for presenting everything. I had a question just in terms of how clinics in general are handling sort of the consent and assent. And, my clinic, it's really honestly sort of a case-by-case scenario. And some parents want to meet with me before they bring the kid in the room. And honestly, we have no formal way of dealing with that. So I was just wondering if anybody did have some type of structure for handling those scenarios.
Hey, this is Michelle. So I can say when I was at MD Anderson, it was nice because there was a policy on when assent and consent was needed. So if the child was 7 years or older, or 7 years to, I think it was 7 to 10 or 7 to 12 or something along those lines. I'm forgetting the exact ages, but I know it started at 7. We had to at least get assent from the child. And then I believe if it was like 10 to 12 or something and older, we had to get written, we had to get the child to like sign their name on a piece of paper. So I think some of that was helpful because, it was an institutional policy. And so, if the parents had issues with it, we could always fall back on that. But I definitely had situations where the parents wanted to meet with me first, before we talked to the children, just to get an idea of, what I was going to say to them. And I was happy to do that. But I did, I was very clear with the parents of what needed or had to be said to the child. And we could always, work together to make sure that they were comfortable with what we were going to talk to the child about.
I would agree with that, Michelle. We also kind of enforce that guideline at Nationwide Children's in Columbus. We essentially do require assent from every patient. We have had some pushback at times from parents. We do have a good psychosocial team, so a lot of times we have our psychologists meet with patients universally, but certainly if there is that pushback, to talk about why it's a preferred approach to inform, your child and have them involved in decision making and the assent process. So we do not proceed with testing without full assent.
Are there any other questions that anyone has for Sarah?
I just wanted to ask if you knew when the AACR screening guidelines that you mentioned might be released and where, like in what journal or?
They're going to be in Clinical Cancer Research, so that's the journal of AACR. I don't know. I can keep the group posted. I know because some of them, like right now, they're being accepted. So we had worked on them, submitted them, we're going through some of the revision process, and I think 2 of mine have now been accepted. So I would think it's probably going to be coming up pretty soon. But we broke up similar, just kind of by more categories of tumors, and then there's also going to be a genetic counseling piece in there as well. I don't know. I know, Cam, you're on. Do you have any idea when they're coming out?
I think they're going to slowly roll out depending on when they're all accepted. I think 3 of mine have been accepted. And all the ones that have been accepted have required revisions.
Yep.
So it's just going to be a slow process of them rolling out. I would anticipate, though, that we'll start seeing a couple of them in May, and it'll be over the summer that the rest of them come out.
Cami, since you're on the phone, I didn't know if you wanted, not to put you on the spot, but just to mention ASPO and kind of your involvement there for the group.
Sure. So I'm headed to ASPO all week next week because I'm presenting twice at the very beginning and the very end of the meeting. The first presentation is going to be on cancer predisposition. It's going to be a 3-part presentation where Josh Schiffman is going to talk about identifying patients. I'm going to talk about the genetic counseling process, and Dr. Garrett Bradour is going to talk about these AACR, the workshop and the surveillance guidelines that are coming out of that. And then there's going to be a talk on Saturday about somatic testing and precision medicine. And thanks to Liz, I will be talking about the secondary findings of somatic genetic testing. And I will be happy to share my slides after the meeting when I summarize to everybody how the meeting went.
Maybe we can have you on a future webinar.
Maybe.
Yeah, we'll have to hold you to that, Cami.
All right.
I also just wanted to update the membership. We are moving forward with an NSGC abstract, so Kristen Zajo is still working on that with Sarah Knapke and some others from the group regarding kind of just an abstract at least on our survey that we did of the pediatric cancer membership. So that should be submitted. And then the referral guidelines, since we were kind of talking about that on today's call, they haven't really been updated from the solid tumor kind of version that was before, since we did add some stuff about automatic referral. But we are looking into like an NSGC formal kind of endorsement of those guidelines, or making it more of an official document rather than just something we post in our SIG kind of document. So, so the general cancer SIG is looking into that for us, so we'll kind of keep you apprised there. And then the other thing, what was the other thing I wanted to tell you guys? Oh, there was a article I had distributed about a McGill kind of electronic tool that is used for triaging referrals. And if you need me to resend that, please just let me know. But I did reach out to the authors of that article to talk more about their tool and using the electronic tool, maybe presenting. It did sound like that author that I was speaking with, our call is actually today, but by email, might be willing to present at a future webinar. So if we can get that secured, I'll let you know. And then also, like, we're going to probably try to talk about whether or not there might be some way for this group to assist in some type of validation of, like, if we were to try that tool, you know, to triage patients, like, is this effective? Is it identifying appropriate referrals? So things like that. So there might be some opportunities there for collaboration. So anyway, I just set up a call with her, and I will keep you guys posted on that.
That sounds great, Liz. Thanks. So we have just a few minutes left. I wanted to see if there was anyone that had, I think Liz had sent out an email when we set up the webinar time to see if anyone had cases that they wanted to discuss, or, you know, any sort of, you know, pressing topics that were coming up in clinic. And so I just wanted to give at least a, you know, a few minutes opportunity for anyone that has, you know, any sorts of these situations in clinic that they, you know, kind of just wanted to bounce off others while we're all here together.
I have a question for the group. I am rethinking our model currently of being involved pre-test for all cases. I feel like when it's straightforward, if I give the physicians tools to do their own testing, that it may be wise to do that with how much our field is changing as far as genetic counseling and our workforce shortage. So I was curious if anyone else does that in this setting of pediatric oncology where you support your doctors in ordering their own testing in straightforward cases.
This is Michelle. So again, from past experience at MD Anderson, I definitely wouldn't do it very frequently, but I would say the pediatric oncologists that I worked with there were less than knowledgeable about pediatric cancer syndrome. But the cases that I would do it was, definitely for like retinoblastoma, because we had a really great system where we saw every retinoblastoma case. And so there would definitely be times where I was kind of in the minimal background, maybe just help assist with like paperwork or something, and then I would see the child after the test results came back. But in most cases, I was seeing everyone pre-test.
Very similar to you, Michelle. This is Liz. There have been a couple where it has been pretty straightforward, like a SMART B1 with ATRT, or we recently had a desmoplastic nodular medulo that was very macrocephalic, and it seemed very appropriate to just go ahead with patch 1, and we did SUPU as well, and it was SUPU. But like there are cases like that where I kind of have had that debate, but so far I've felt that even if the oncologist knows what they want to order, that their ability to explain it to the family sometimes is limited, and so I still have felt like it's been helpful to have the conversation with the family and get the consent, even if I do kind of like an abbreviated, like a lot of times what we'll do in that scenario is the oncologist will actually introduce the testing, and then I'll just kind of more come in, take the pedigree, and do pretty efficient kind of like consent. So that's how we have handled it, but I'm still involved pretty much in every case doing pre-test.
Okay, any other questions, pressing clinical issues that people have kind of come across?
This is Sarah. I actually had a question for the group. So we have been, and it may just be the service is becoming more aware of it, but we have been getting a lot more thyroid cancer referrals. And so I was just wondering what others, my approach at this point has been just ordering a panel of thyroid cancer genes, but I'm just wondering if anyone else is seeing these patients and what your approach to evaluation, aside from like an obvious P10 case, but if anyone has any suggestions of or what they're doing.
This is Martha. That's really interesting that you say that. We had 3 thyroid cancers diagnosed within 2.5 weeks of each other here at UVA. So I personally went with the panel approach. They were all teenage girls, 14 to 16 in ages. So I personally went with the panel approach, but that's interesting because I wonder, I don't know, just an N of nothing, but I have dealt with that a lot. And we've seen a follicular, a CMV, and a papillary, so they were all different.
Yeah, and I mean, I don't think our pickup rate hasn't been very high, so it's also, I don't know, should we be testing them, should we not be testing them, but I've just gone with panels so far.
This is Cammie. I've had some back and forth with our endocrinology department because we kind of thought that we should see all of them, especially because some of the genes that I would put on a panel that could be de novo or you wouldn't necessarily expect a family history. But then I think because of these low hit rates and lack of data to support that these early thyroid cancers, there's just nothing out there that says what percentage of them are hereditary. There was a period of kind of holding back on the endocrinology side of do we really need to send all these patients. But for the ones I do think about the genes if there's no other clinical history that would fit and consider a panel as well. I've typically mostly just done TP53 and P10. But I think it's been on a case-by-case basis, and we haven't had a huge volume.
Okay, I think if there's no other topics, we could probably go ahead and wrap it up with about 2 minutes left in our time. Again, Sarah, thank you so much for presenting this, and to all of your co-authors for working together to get this wonderful publication out there. I think this was really great. So thank you all for that. And thank you guys all for signing on and participating in our further discussions and questions. It's always good to hear what people are dealing with in their clinics. And then we will. Liz, I don't know if you have anything additional, but otherwise we will let you guys know when we're going to have our webinar next month.
Yep, I'm good.
Okay. Thank you all very much. Have a wonderful day.
Thank you.
Bye.